Good evening. Thank you for being here with us. My name is Mariana Wertzman, and on behalf of the Stavros Niarchos Foundation, I would like to welcome you to tonight's program. First and foremost, I would like to thank the Stavros Niarchos Foundation for making this program possible. We hope that you can take advantage of wonderful lineup of speakers we have for you for the month of May and beyond. If you don't have a library card, please see some of my colleagues throughout the building. They'll be more than happy to assist you in getting a library card. Today marks the beginning of a Mental Health Awareness Month in the New York Public Library. The focus of tonight's program is on policies that can help sufferers of serious mental illness. As an information professional, and somebody who was involved in debate formally, I would provide you with a definition of serious mental illness. But I find that most definitions, whether they're clinical or functional, fail to capture what is truly important about this particular group of brain diseases. Many of you in the audience are probably wondering about the difference between poor mental health and a serious mental illness. I would like to share a very personal story that might help you make that distinction between poor mental health and serious mental illness. In 2022, I was diagnosed with cancer. As you can imagine, that diagnosis didn't do much to improve my mental health. A few days before scheduled operation at the Memorial Sloan Kettering Hospital, I inquired about the particulars of my post-surgical recovery. After sizing me up, a nurse bluntly informed me what I would feel like I was hit by a truck. She was right. I felt that way. After a marathon procedure, during which Dr. Cody and Dr. Nelson rearranged my entire torso and put me back together, I finally woke up to a new reality. In addition to lightness and excruciating pain, I instantly recognized the fundamental change in my perception. I have acquired an extraordinary acuteness of the senses, a superhuman ability to perceive things unseen by others. So shortly after becoming conscious, I did begin to see things others did not see and could not see. Emboldened by the departure of the medical personnel, little furtive creatures finally revealed themselves. Distorted human faces that escaped from Goya's capriccios were floating right above my bed. Whenever doctors entered my room, those furtive monsters became transparent and disappeared under the bed. Alone and helpless, I lay there utterly petrified. Directly opposite the bed, there was a large screen TV, and it slowly lost its shape and morphed into a deep vortex, a getaway to an abyss. A figure with deeply carved face and long flowing hair emerged from it. I was saved by a group of medical students that entered my room. Finally, I demanded to see a psychiatrist, but was told my insurance doesn't cover that specialty. Shortly after my release, I paid for a private assessment and was told that my condition was probably an instance of post-surgical psychosis, also known as the post-operative delirium. It's a temporary state of brain dysfunction characterized by altered perception that involves visual and auditory experiences that are not real. My break from reality was incomplete, brief, and temporary. I had a tiny glimpse of the horrors that people with untreated schizophrenia experiences. But I learned my lesson. This is what I know now. To live with untreated mental illness, serious mental illness, is to suffer in the ways that most of us can scarcely imagine. Tortured by voices and in the grip of paranoia, SMI sufferers are utterly helpless against the horrors that their malfunctioning brain inflicts upon them. A cancer patient or an Alzheimer's patient would not be released to the community. Why is it that we release those tormented souls with a progressive and debilitating mental illness into the community so they can remain in the libraries and sleep on the train. What is our collective responsibility towards the sufferers of SMI, their families, and how do we help them while protecting them and the public? This and many more questions will be discussed by our distinguished guests today. Brian Stettin is a senior advisor to severe mental illness for the Office of the New York City Mayor. He works in collaboration with city agencies and the city's public hospital system to develop and implement policies that prioritize psychiatric care that support New Yorkers in greatest need. From 2009 to 2022, Stettin was a policy director for the Treatment Advocacy Center, a national organization dedicated to removing barriers to the treatment of severe mental illness. In this role, he drafted advocacy for legislation enacted federally and numerous states to improve civil commitment laws and expand access to mental health treatment. Stettin also, Brian Stettin also led tax efforts to support communities across the USA in establishment and then operations of assisted outpatient treatment. He was also the he was also instrumental in implementing the proposal of Kendra's law, New York City's AOT law in 1999, as well as significant amendments enacted in 2006. He is a graduate of City College of New York and University of Texas School of Law. Stephen Eide is a senior fellow at the Manhattan Institute and a contributing editor of the City Journal. He researches social policy questions such as homelessness and mental illness. He's a 2024-2025 public scholar at the City College of New York, New York's Moynihan Center. He's written many publications, including the book that we have right here in the library. The History and Tragedy of Intractable Social Problem was published in 2022. In addition, he writes for New York Post, New York Times, Politico, Wall Street Journal, and many other publications. He holds a BA from St. John's College in Santa Fe, Mexico, and PhD in political philosophy from Boston College. Please welcome our presenters.
Well, thank you, Mariana, for that introduction. Thanks to the library for this opportunity to be here. I briefly want to say something about just how important this institution has been to me over the years, personally and professionally. My introduction to New York City politics, when I came to the city in the early 2010s, the first issue that I followed very carefully was something called the Central Library Plan controversy, which is about this plan to kind of restructure and change the institutions in Midtown, including this one. It didn't happen in the way that the library leadership imagined, but at the end, you got a much nicer building here called I still call it the Mid-Manhattan Library, and much nicer carpets in particular. I remember the carpeting at the old Mid-Manhattan was just odious. Like, you guys don't have to blow up the library if you just replace the carpets. I'm also keenly familiar with the ways in which these issues of street homelessness and untreated serious mental illness affect the library. I wrote about this back in 2019. I interviewed the NYPL leadership about it, and I visited for that project 60 to 70 branches across the city to get a sense for what they were up against. I've also visited over 250 public libraries in America, and most of those visits I was kind of attending to the situation with the street homelessness, untreated serious mental illness. So New York is not alone, so libraries across the nation are really kind of up against it when libraries across America are in the homeless services business, whether they ask for it or not. But let me turn to Brian and the issues of today right here in New York City, and in particular, because there's a lot going on at the city level, at the state level, a lot of good things going on, actually. You know, just like with the Mid-Manhattan Library, sometimes things get a little better, not completely better, but there are improvements sometimes. So let's begin, Brian. I think we need to kind of communicate the basics, what's going on. Mental health, New York, big issue. What specifically are you in charge of?
Sure. Thank you so much for the question and for the invitation to be here. I'm really grateful to the library and to Mariana for making this event happen. So it's actually a great question to start with, because my title, Senior Advisor on Severe Mental Illness to the Mayor's administration, I think sometimes gives people the idea, the misimpression that I am the mental health czar for the city, that I'm overseeing all the city's myriad efforts to make sure people with mental illness in general are connected with treatment. And of course, most of that role would be, if in fact I had it, would be about connecting people with services that they are actively desirous of. And I would say probably that is a description that more accurately fits Director of the Behavioral Health Unit at our Department of Health and Mental Hygiene, Dr. Jean Wright. My own role, I come at this as an attorney, not a clinician. And my role in the administration is much more specific than that. And it's a really hard thing to capture in a title. But I am focused on using the law, leveraging the authority we have under the law to make sure that we are optimizing our use of involuntary treatment, right? To make sure that people who are experiencing the most severe mental illness, who are not aware of the fact that they have mental illness and a desperate need for treatment, however obvious that may be to everyone around them, are able to receive the care that they need and deserve. When they're not asking for it and not wanting it by no fault of their own due to a lack of insight, what can we do as a city to make sure that people are actually going to get that care? And so my role, I'd say, is about developing strategies, policies, operations that involve coordinating multiple agencies. Most significantly, our city-operated hospital system, the agency known as H&H, our Department of Homeless Services, because we're largely talking about people who are homeless and unsheltered, and of course our Department of Health and Office of Community Mental Health, and our police department and fire department, of course, all have roles in that. So from City Hall, I am really all about making sure that we are doing the best job possible using the laws that we have at our disposal to ensure treatment for those who can't recognize their own need for it.
I mean, it seems like such a daunting challenge, to any average subway rider, anyone who's followed the debates about homelessness and mental illness for years. So the question I would ask is, what does success look like for your job? And I want you to answer that in a twofold way. What does success look like in terms of the individual lives of the people who are living on the subway, not receiving treatment? You're trying to move them to something better. What does that trajectory look like? Also, what does success look like for the ordinary New Yorker who just doesn't understand why conditions on the subway and streets just never seem to get much better?
Sure. Well, I think it's probably important to make clear that although my role is very focused on the need for involuntary treatment as a starting point to get people who are in psychiatric crisis on the road to recovery, I wouldn't want anyone to have the impression that I think that that's what this is all about, that like getting somebody to that good place that you're asking about, that ultimate level of success that we want to reach with each individual is simply about waving a magic wand, getting them involuntary treatment, and then all the other things are just going to fall into place. That would be a very myopic way to look at the system. And so certainly there's a recognition in everything we're trying to accomplish that getting somebody in the door of the treatment system, that is when they're in psychiatric crisis on the street, getting them to a hospital is a first step on a long road to recovery, and any ability we're going to have to ultimately get that person to the best possible outcome is going to depend on having lots of resources and services in place. And what I think it all comes down to for the individual at the end of the day is getting that person into, and this is language that really comes out of court precedent. What courts have said is our obligation to people with the most severe mental illness, getting each person into the least restrictive, appropriate environment for them where they can thrive and live safely and in stability. And for the great majority of people with severe mental illness, that's going to be a community setting. So we're bringing people to the hospital not as an end in itself, as a means to an end to help restore them to where they can come back to the community and actually have a fighting chance of succeeding in a community placement, and that's going to mean supportive housing, right? That's housing where they're receiving services, ideally on premises, that'll help them stay in the community, and most of the people that we're working with are going to get to that place. I think it's also important to recognize that that's not a realistic goal for every single person, and for, there is a minority of people with the most severe mental illness for whom community placement is not really going to stick, because their illness is just too profound to allow them to stay in that kind of a setting. They're going to have delusions or fears that are going to drive them back out to the street. And so I do think there is a minority of individuals that the least restrictive appropriate setting for them is going to be an indefinite period of hospitalization. And I think we're doing a disservice to people if we regard that as a failure in any particular case, right? The real question with each case is, have we done everything we can to get that person to that least restrictive appropriate setting for them? And, to recognize that for some people it's a choice between long-term institutionalization and rotting to death on the street. I don't see that as a systemic failure. I actually see that as a form of success. But again, I want to stress that's not going to be the ideal outcome for most of the people who we're bringing into care. To the second part of your question as to how I see this bringing a sense of accomplishment to the general public. Look, we've been for a long time taking for granted that seeing people in psychiatric crisis in public spaces, particularly in the subway system or in parks, is kind of a regular feature and a really unpleasant feature of city life. And people are often afraid when they see somebody exhibiting psychosis. And I don't think people are irrational to find that scary. And so, I would like to get to a point where that becomes a less commonplace experience for somebody living in New York City. I think it's probably unrealistic to expect that that's going to become something unheard of, given the size of the population we have here, how concentrated we are, the fact that we have a lot of people coming out of psychiatric hospitals with very severe illness, and sometimes they drift off of their medication, or their medication isn't as effective as it could possibly be, and so we're going to sometimes see people in psychiatric crisis. I do think we could do a whole lot better in making that more of a less common occurrence than it is now. And so, I look at metrics like what riders tell the subway system, right? The MTA does surveys of the concerns that riders have about what might make them uncomfortable in the subway system, or what might keep them from using the subway system more than they currently do. And the number one, year after year, has been the experience of encountering people who are in psychiatric crisis. And I'd like to see that move down that list at least a few notches, and I'd consider that a form of success there.
I think one way in which things have gotten slightly better in recent years is that we have better leadership at the state and city level. In the 2010s, you had the dynamic duo of Bill de Blasio and Andrew Cuomo. Mayor de Blasio, although he wanted to be kind of defined by his mental health efforts, was really interested in more of kind of wellness, the milder forms of mental health, and really paid a political price over not attending to the issue of untreated serious mental illness towards the end of mayoralty. Governor Cuomo, although Governor Cuomo, if you know anything about his backstory, he had a lot of experience early in his career working with homelessness, really distanced himself from that issue and did a lot of bad things at the state level, particularly cutting psychiatric beds, which wasn't really noticed at the time, but which did a lot of harm for New York City, I would say. Now, Mayor Adams, it's been a wild ride for the Adams mayoralty. And it's the poll numbers suggest that he's going to face some turbulence this election. But the one thing I try to emphasize is that the leadership on mental health has been great, in my opinion. I mean, he talked about it before he became mayor, very early on. I have a plan. Let's implement the plan, and it's been working. You guys haven't had to pull back on that. And Governor Hochul, every budget that Governor Hochul has put together, she has done useful things on the serious mental illness front. We dug ourselves a deep hole, but she's been very helpful. I want to ask you about the state. What just happened? So we just had a budget. It was just put together this year. The reason why it was late was one of the sticking points was this debate over involuntary treatment. So what was just in the state budget, and how's it going to help you?
Sure. So we're very excited about some of the pieces that have now been enacted into state law through the budget process. I'll tick off the highlights, but I should say that this all really began as a piece of legislation that we, as the Adams administration, introduced called the Supportive Interventions Act that we've actually had out there now for a couple of years. It was first introduced in 2023. It was a little hard to get traction on it. I think we knew all along that the way to get some of these things enacted was to have them become part of the budget process, which meant getting the governor on board. And we were really delighted this year that certain key pieces of that legislation, not all of it, but a number of the provisions of that bill became part of the governor's executive budget this year. Now, although we haven't seen the final language, it appears that the governor has prevailed in getting some of these things enacted. So let me speak to what specifically is in there and how it's going to help. The piece that's gotten the most attention is language that's going to make explicit, for the first time in New York, but really bringing us in line with the laws of 48 other states, that when a person is in psychiatric crisis and a decision has to be made about whether to bring them involuntarily to a hospital when they're unwilling to come on a voluntary basis, and then ultimately, once they're evaluated in a hospital, whether to admit them for care, there's a determination that has to be made as to whether, first of all, this person is in fact mentally ill, but secondly, whether they are a danger to themselves or others. And that's standard across the country. From state to state, you'll see that language in one form or another. The definition of danger to others, I think, has been reasonably straightforward, but what it means to be a danger to oneself is where we have had a lot of frustration in New York, in that the law has been interpreted very narrowly. And it's not that there's language in the statute itself that says that danger to self means this one specific thing, but the law has been vague, and in the vacuum, it's been filled in with people's interpreting it to mean only that a person is suicidal, or they are engaging in some outrageously dangerous conduct, such as running into traffic or trying to step onto a train track that puts them in imminent risk of physical harm, or that they have some dire medical condition that they're ignoring because of their mental illness that, again, has them at imminent risk of harm. And, you know, this notion of imminent risk is so kind of baked in to the mentality of how this law has been interpreted, both by outreach teams on the street making decisions about whether to bring people to the hospital, also by doctors in hospitals making decisions about whether to admit people, and also by judges who have to make these calls when these cases come to court, when people use their due process rights to challenge their involuntary commitments. And what that narrow conception of danger to self has left out of the equation is the notion that a person can be a danger to themselves by virtue of their inability to meet their basic human needs of food, clothing, shelter, or medical care. And so if you think of the person whose mental illness causes them to be unsheltered and just in really horrible physical condition, filthy, and you can smell urine on them, or you might see lice on them, and you can see that they're emaciated, that person may not be at imminent risk of physical harm, but that person is on a very sure path to self-destruction. We ought to be able to recognize that as a form of danger to self. And in fact, the courts have long said in New York that we can interpret the law that way. And so that's why our city policy has been all about that since Mayor Adams came into office in 2022. We've been operating under the assumption that that's what the law means, and we've had tremendous success in bringing people off the street and also getting them admitted to our city hospitals. But this pervasive myth that danger to self only means, the things I mentioned, sometimes has derailed us in getting people admitted to hospitals because doctors cling to this misunderstanding of the law, or judges sometimes have released people prematurely before they have received enough care. So what the governor has done, again, taking language from our bill, is to put that language explicitly into the law to really kind of end the debate we've had with some advocacy groups over the years, and just make it crystal clear to everyone that danger to self means more than just the idea that the person is an imminent risk. And so the people that we have historically walked by are now going to, I think, more consistently receive care. We're really excited about that. A piece that goes hand in hand with that I'll also mention is that the law will now say explicitly something which I think should be really common sense, which is that when a doctor is making an evaluation in a hospital to determine whether somebody is currently a danger to themselves or others, they have to consider more than just how the person appears at that moment, sitting across from the doctor at a table during the evaluation. Because, you know, you have people who have been through the system a lot, who have developed the ability to hold it together for a few minutes while they're being evaluated. Or maybe they've received some medication in the hospital and they came in the night before, and then another doctor comes on shift the next day, sees a person who's a whole lot calmer than they were when they first came in, and they're looking at a person who does not appear to them to be dangerous, and so they say, well, I don't have grounds to hold you anymore. We now will have language explicitly in New York state law that makes clear that when you're evaluating whether someone is a danger to themselves or others, you have to consider the full context. You can't make that decision based solely on how the person appears in the moment. You must also consider their history, their recent behavior, what led them to be brought to the hospital, whether they are now ready to stay engaged with the treatment they may have received in the hospital on an outpatient basis. And so those decisions, I think, will lead to people staying in the hospital for a more appropriate length of care. So those are the couple of things we're excited about.
So you alluded in your remarks to the advocates, the pushbacks. Let's have you respond to the critics. And I'm going to try to steelman that position as best I can. So the first part, criticism, is of what you're doing and this whole push is that we already do too much involuntary treatment. Okay, and again, I'm trying to present this so everyone is aware vaguely of the story of deinstitutionalization of the mentally ill. We used to have, 550, 600,000 institutionalized adults with serious mental illness in the 50s. Now it's down to like 30, 40,000. New York, it went down from 90,000 to maybe 4,000, something like that. So deinstitutionalization, that's a staggering drop. But in terms of the people riding what we sometimes call the institutional circuit, moving from jails, from streets to shelters, involuntary treatment is a very common experience for that. So that's what they have in mind when they say that we're already doing too much of that. And connected to that, what you're talking about is triage. Okay, you're just trying to deal with crises. The advocates would say we are interested in long-term solutions and ultimately getting, really somewhere with this, whereas you're just in this kind of responsive crisis mode. Yeah. So that's a criticism. Take it from there.
Sure. Well, to start with the last part, we don't have the luxury of choosing the battles here, right? When we encounter somebody who is in acute psychiatric crisis, as so many of the people we see around us, just as New Yorkers every day are, we've got to make a decision of whether we're going to get this person into care. And, we could walk by and say, well, we have a system that just doesn't meet people's needs as early as it should. Maybe there were missed opportunities that might have prevented that person from being in this situation right now. And so we're just not going to do anything about it. We're just going to kind of work on those larger issues and leave the people who are in psychiatric crisis now alone to rot. I don't think that makes a whole lot of sense to people. And so to me, it's about getting the person in the door of the treatment system, because any hope we have of connecting them with the long-term supports and treatments that they are going to need to, again, reach that place where they are in the least restrictive, appropriate setting for them, really has to start with medical care, right? We've got to get that person into a hospital and stabilize them, get them on the right medication, and help them kind of learn some basic habits of self-care that may have been kind of unlearned through what they've experienced, and that may take a period of time in a hospital. And so we have to have laws and policies that facilitate that. It's the first step. It's not the entire answer, but for somebody who we're encountering in psychiatric crisis right now, there really is no way to get them to that good place without starting there. And so what was the first argument that you asked me to respond to?
We already do too much.
Yeah.
Those people in particular have had a lot of encounters with the hospital.
Yeah.
Didn't work before. Why is it going to work this time?
Right. So because of the way we have narrowly interpreted those laws, those folks are very often stuck in a revolving door where they may come in to a hospital because they're acting erratically in the community in a way that a police officer or a clinician brings them to a hospital. But typically they're coming to what's called a CPEP, right? A psychiatric emergency room where they can be held for up to 72 hours for evaluation. Because of the narrow interpretation historically of those laws, they're getting released too soon. right? They're not getting admitted for care into this hospital psychiatric inpatient unit. And if they are, they're considered stabilized much sooner than they would if the laws were being interpreted correctly and if all this information was taken into account when we made decisions about people. And so we're missing opportunities to get people hospitalized for the right amount of time when we see them the first time. And so we keep kicking that problem down the road, kicking that can down the road with the same individual again and again and again. Very often the person winds up in the clutches of the criminal justice system, and then they may come to the hospital on a forensic commitment because there's a question of whether they're competent to stand trial. And so the treatment that they're getting in the hospital is really only about restoring their competency so that they can be put on trial and then maybe sent away into the penal system. And of course, then they're at some point going to get back out. We've never actually dealt with the problem in a holistic, sensible way. So by having the laws on the side of effective treatment, I think we can get people out of that cycle. And another really key piece of that is something Mariana mentioned earlier, a Kendra's law, assisted outpatient treatment. Having a treatment plan, a discharge plan that's designed for somebody when they come out of the hospital, delivered under a court order. That is for somebody specifically who has demonstrated this kind of revolving door history of difficulty adhering with their treatment, so that we can be more proactive and respond to a person's going off that medication, disengaging from treatment, before they act out in some dramatic way that exhibits their dangerousness to themselves or others, which again might then at that point have them in the clutches of the criminal justice system. So really what this is about is kind of creating a seamless path through the treatment system in a way that's going to keep people from falling out, falling in, falling out, falling in. And I think we can treat people a whole lot more effectively and efficiently if we do that.
Yeah, I mean, I often feel like that the appropriate horizon for success in policymaking is not the short term, not the long term, but kind of the intermediate term. It's possible to be overly interested in the long term because in the long term we're all dead, right? I'm reminded of this passage in this book that was written by a man named Dr. Tom Insel. Dr. Tom Insel is a very prominent psychiatrist, and he led the National Institute for Mental Health for many, many years, the world's largest funder of research about mental health. Funded billions and billions of dollars of research, particularly about the brain, the biological basis for serious mental illness. And he has a story in his book about how it's a publicly funded organization, so he did lots of public events in this capacity. And he was in Portland, Oregon, and giving this talk about all the great new research, about the new things they're finding out about neurotransmitters, et cetera. And when it came time for the Q&A period, this very angry man stood up and asked the first question and said, quote, you really don't get it. My 23-year-old son has schizophrenia. He has been hospitalized 5 times, made 3 suicide attempts, and now he is homeless. Our house is on fire, and you are talking about the chemistry of the paint. What are you going to do to put out this fire? And this is an eminent psychiatrist, eminent mental health expert, and he really was brought up short by the idea that you can't just take recourse and say, well, eventually everything will get all better. You do need to kind of respond to what's in front of people right now because people are really suffering. With regard to an issue that Mariana touched on in her remarks, this difference between mental health and serious mental illness. This has often kind of bedeviled some of us who are trying to really keep the focus on serious mental illness. There's this whole May is Mental Health Awareness Month. We're going to hear a lot about all kinds of things that are defined as mental health challenges, and one wants to be very sensitive to all of that. But at the same time, if all of the emphasis on that, then the people with the really most difficult challenges get ignored. That has happened time and time again. The governor, however, seems to me an interesting case here because if you look at what she has done, she has both responded to the people who want something done about youth mental health or something like that, but has also done things like added psychiatric beds, made the changes to the law. So how do you think about that? How do you think about the difference between those two? Do you really need to focus or, yeah, that's all.
Yeah, no, and it's such an important question. As someone who's worked in this mental health advocacy space for a long time and been really focused on the needs of people with the most severe psychiatric disorders, it certainly has been a frustration of mine that there is a tendency sometimes to lump all mental health issues together, as if there is something connected or something similar about the kind of the everyday mental health struggles that so many of us have, 1 in 5 people is estimated to have some kind of mental health condition, and I would never want to, sometimes we use the term serious mental illness to describe the most severe forms, and I'm never comfortable with that, because I would never want to suggest to somebody that their depression or their OCD that's impacting their life in a really significant way is not serious. It's certainly not trivial, but I do think that we sometimes go off course with policy when we lose sight of what makes illnesses like schizophrenia and severe bipolar disorder fundamentally different. That is, mental illnesses that untether a person from reality, that are sometimes accompanied by this lack of insight, right? There's an important clinical concept, a neurological syndrome known as anosognosia, that so often accompanies mental illnesses that cause psychosis or mania. And that essentially means that a person is fully unaware of the fact that they have an illness that you just don't see with people with OCD or depression or anorexia, or there are any other more kind of common conditions. And so the argument that we make as to why there needs to be this involuntary treatment mechanism, I think, is sometimes harder for people to understand when they're thinking of mental illness as a monolith. Because in general, it is certainly true that we don't want to interfere with people self-directing their own course of treatment. I think that's an important principle that in general we have to respect as a society, and I'm right there with it. But I think the rationale for that really does sort of fall away when you are talking about forms of mental illness that come along with lack of insight, right? Mental illnesses where a person, it's not just that they're in denial. We sometimes refer to it casually as denial. When you're in denial, you actually do know the truth deep down. You just might need a little bit of help coaxing that to the surface. Anosognosia is neurological. People experiencing that, they don't know the truth deep down. The information is just not reaching the part of the brain that allows them to recognize what is happening to them. And so they are certain to their core that they don't have an illness. And that really changes the moral equation in a significant way, and it actually becomes, I think, a moral obligation for us to do something to help that person. And as I say, I think the fact that we lump all mental illnesses together and think about kinds of conditions that we all might find more relatable, I think that gets in the way of us understanding why it is so important that we have involuntary treatment mechanisms.
I want to bring this around to libraries, but it's going to take a second. I had the opportunity last year to spend some time studying the mental health system in Norway. And one thing that struck me about their community mental health system is that there was just a kind of coherence and accountability to that system. It was just kind of organized in a clearer way, whereas particularly when you're talking about the community mental health system here, it's just like a ball of spaghetti. I mean, there's just programs, everybody's doing something, it's just, there's no coordination and no accountability. And part of that, what's going on there is that you have so many agencies that are not mental health agencies in this business, in this game. Libraries, transit systems, most notoriously the criminal justice system. Sometimes it seems like the mental health agencies are the ones not dealing with the most serious cases. They're in the jails, and then the mental health system is dealing with the less serious cases. That's the impression one has sometimes. So, how do you think about kind of trying to put together the system into a more coherent way, and also create a situation where there's more accountability, particularly for serious mental illness, within the mental health system? I mean, is this a question of like coming up with like interagency coordinating groups and like you want to work with these other agencies? I mean, in a practical sense, I guess you have to do that, but it seems to me it would be great if we could work towards a situation where responsibility for serious mental illness is squarely placed with the mental health agencies and not all these other departments that have other things to do.
Absolutely. I certainly couldn't agree more. I do believe if we focus on creating a more functional mental health system, that problem will, if not completely, the problem you're identifying of having this issue fall into the lap of organizations and entities that are really not equipped to address it and really not designed to address it, I think that problem will be greatly minimized by having a more functional mental health system that addresses people's needs before they wind up, engaging in activities that force the criminal justice system to address them, and before people, wind up encamped in libraries or in subway systems because we haven't found an appropriate place for them to go and haven't recognized their needs in a meaningful way. So I think by building a great public mental health system, we can sort of take this burden to a large degree away from some of these other institutions. But again, coming back to the kind of realism that I tried to bring into the conversation earlier, it's probably never going to fully go away as something that places like libraries and operators of transit systems and even our criminal justice system are going to have to deal with sometimes. And, I think the focus has to be on diversion, right? It's about when we can identify, particularly for people who commit criminal acts that are driven by mental illness rather than any kind of inherent criminality in the person, where the person clearly needs treatment much more than punishment. We've got to develop, and I think we have some great things happening in this regard now. We have to develop mechanisms where we're diverting people out of those systems as early in the process as possible, certainly before they get to a place like Rikers, which can make mental illness so much worse.
Earlier you talked about, when I asked you what success looked like, you envisioned a picture that I share, which is that, you want to put someone in a place, in a situation where it allows for the possibility of recovery, of improvement, but also if they're still there 10, 15, 20 years later, that's okay too. For some people that might be housing, for some people, others it might be a more kind of like asylum-like situation, long-term inpatient care. There's another vision of kind of what a mental health system would look like, kind of what sometimes you call the continuum of care, and you imagine people like moving through different programs based upon where they are. But I think you need a kind of basic degree of stability you want, allowing for, again, improvement, but not necessarily expecting it, demanding it. To what extent does this come down to just kind of the elusiveness of the underlying mental illness, of the condition, and of our kind of limitation in understanding both what schizophrenia is and also what it may mean in an individual case, because it would be very different in individual cases. Like, I sometimes compare it with this, the situation of Alzheimer's and dementia. Well, it's kind of going to be downhill. All right, you don't know exactly the trajectory, but you know where it's headed. People with developmental disabilities, IDD, there's a kind of flatness. You can allow for some improvement, but with SMI, with serious mental illness, there's this kind of like cyclicality to it. And someone can be in such a different position year by year and at different points in their life. You thought everything was stable, everything was in place, and then something snaps and we're back to where we were, and we're back to a very bad place. So to what that's a very hard thing for policy to respond to, and is it just kind of this underlying elusiveness to the thing we're working with?
Well, I think we have to develop treatment modalities that recognize the need for constant vigilance and constant attention to people who are living with these illnesses, right? You get somebody into permanent supportive housing, that's not the end of the road, right? It's not like we can now, wipe our hands and be proud of ourselves. We accomplished something and we're done. Supportive housing means supports that are in place in that person's life on a very regular basis, right? And some people need to be seen daily or weekly in terms of checking in with them and seeing how they're doing. Sometimes it's not even the person is disengaging from their medication, which for some people is a constant challenge and a constant threat. But sometimes the medications become less effective and need to be adjusted. And so you have to really be keeping eyes on that person constantly to see how they're doing. And so I think it's really just about recognizing that that's what it takes to keep somebody safe and stable in the community in the long term. It's about being there with them and for them at all times. And that's why, I think that the supportive housing models that work best are those that have treatment services on premises, so that we're really kind of keep constantly staying engaged with that person.
Yeah, I think we're almost time for questions, but just, one last thing I want to emphasize about the case for optimism in this issue. So I'm slightly optimistic. I mean, I think that, first of all, the number of beds, psychiatric hospital beds, I don't think they can go lower. I think this is going to be the first decade where we didn't lose beds. We might actually gain some beds.
Yep.
And I also think that, and this is me being totally a starry-eyed optimist, I think there is some opportunity for some bipartisanship on this issue, if no other issue. I mean, that may be a very low standard to clear, but there is, I think, reason to think that it'll take the right kind of constellation of political circumstances, but we may have some breakthrough at some point at the federal level. There's some good things that happened federally with both parties coming together in 2010s. There's this issue of Medicaid funding and for psychiatric hospitals. So there, I think, compared to other issues and compared to where things were 20, 30 years ago, I think we're in a slightly better case than we were now. But I'm getting signals about that it might be time to do some Q&A. Is that right? Okay.
Yes, thank you so much. Thank you for such an informative talk. And if anybody has any questions?
Hi, thank you very much. This was it was an incredible discussion. Thank you so much for being here. One issue that I wanted to touch on is like a story I hear, unfortunately, too often of family members and loved ones that are searching for severely mentally ill individuals either on the streets or within the system itself. And I suppose my more general question is what can be done for those people given like the more disorganized nature of the system, and then also maybe privacy law and other things that could provide barriers to recreating a connection between patients or severely mentally ill people and their support network.
Yeah, thanks for that question. Obviously, it's a critical and really heartbreaking issue that we see so many families struggling with just trying to get basic information about what's happening with their mentally ill loved one who has disconnected from the family. It's hard because we have federal health privacy laws that hospitals are very cognizant of and very worried about what liability they may create for them that make them reluctant to share information without a person's consent. One thing I think we've done in our H&H, our city-operated hospital system, has made it part of the intake process, part of how we engage with patients, is to encourage them to allow us to share information with loved ones and get their permission to get in touch with people who may be out there wondering where they are, and we try very hard to get a person to the place without kind of browbeating them about it, where they give us permission to make those connections, and we've, I think, done amazing things in bringing people back together with their loved ones. But when you have a situation where a person is unwilling to allow you to share that information, I think it's really going to take a change in federal law to get us to where hospitals are able to overcome that. And I do think we might consider whether these laws that are really designed for illness in general, not specifically for mental illness, really should be kind of set aside when we're dealing with illnesses that might give a person an idea that their loved ones are trying to harm them rather than help them and stand in the way of that information getting delivered. In situations where the family is aware that their loved one is in a hospital, and they're trying to get just information about how they are doing, there are exceptions to the health privacy laws that actually allow a doctor to share information when they believe it is in the patient's best interests, and where they think it's actually going to help foster that person's recovery for their loved one to know certain things that I think are not widely understood enough, and the federal Department of Health and Human Services actually put out some guidance on that. If you get in touch with me, I can share that with you, that I think we could probably do a better job of getting more hospitals aware of, because there is sometimes an idea that it's absolutely impossible to share any information with loved ones without the patient's consent. Another thing that frustrates me is sometimes there's a belief that you can't even listen, you can't even receive information from loved ones that might be incredibly helpful and instrumental in providing care to that person in the hospital. And there's absolutely nothing in the health privacy laws that ever prevents hospital staff from hearing what families have to tell them about what kind of treatments work and don't work for their loved ones. So that should never be happening. And the fact that it does sometimes is a frustration of mine as well.
Yeah. Just very, very quickly, I mean, that's my standard of success, usability from the family's perspective. How usable is this mental health system from the perspective of families with seriously mentally ill loved ones. That's what I saw that they had in Norway, and that's what we really need to get to in here in terms of just more kind of coherence and usability. I mean, now the way it works is, you know, you're a parent, a mother, and you have this child who's having a break, and it's beginning to dawn on you that things are getting very, very serious. And that whole future that you had projected of, you know, graduation from college and, you know, getting started in your professional life, you know, marriage, grandkids, you realize the future is going to be very different. But what does that mean? I mean, you're online, you're reading about all these things. How do you translate to what's available to you in your community? Every mother in America can't figure that out. That's the system that they're just wrestling with. And you have to make, even when you do make it your professional job to figure out how to use the system, you often fail. So that is what we need to get to, just this basic level of being able to use the system in a way that someone in that position just can't figure it out. Because the people who we have to provide housing to down the line, those are the people who have no family left, but they did once have a family. And if we could do more to support that situation, then we would have to provide less housing, among other benefits.
Yeah, I'd also encourage anyone listening to this to get in touch with the Treatment Advocacy Center, the organization I worked for 13 years. They provide some really tremendous resources for families to equip them with knowledge of the law that they can use when they're being told things that just aren't true by care providers.
Hello, I'm so honored to be here. I'm a student at Academy of Peer Services. It's a program for peer support professionals. It's a program given by the New York State Department of Mental Health, Office of Mental Health, and Rutgers University. And I would like to know if you guys are aware of the role of peer supporters and the role of giving support to persons that are homeless with mental illnesses and addictions that will reduce the rate of recidivism in hospitals and jails. And do you think that we should, as community, hire more of these peer supporters to address the problem of homelessness and mental illness and addictions to effectively solve this issue?
So I'm a big yes on that. I'm a great believer in peer support. I have seen remarkable things happen in terms of engaging with people who really had walls around them and didn't want to participate in treatment, and how those walls can come down when they have somebody who's walked that same path as them, who's been through it and has gotten to a good place because of treatment. And just that ability to relate to somebody that sometimes a clinician does not have, I think has an enormous role to play in achieving recovery for folks. And we need, I think, you know, we can't just hire lots more peer supporters with a flick of a switch, because we've got to actually train and develop people to perform that function. We've got to do a whole lot more recruitment, I think, among people who have been through the mental health system and gotten to a better place, to actually create that army of folks who are going to go out into our treatment system and play that important role. One red flag I will raise, and the thing that has concerned me a little bit, is that I have seen in some circumstances, I don't think this has been an issue so much in New York City, but I have seen in some other communities where I've done this work nationally, that sometimes some of the organizations that have been contracted to provide peer support kind of come down on the side of self-direction is the key to recovery, and are sometimes reluctant to encourage people to stay engaged with treatment that they don't personally want. And I think that in circumstances like that, it can be a little bit dangerous when you have somebody encouraging somebody to not engage with treatment. But you know, I don't think that's at all inherent to the notion of peer support, and I think that you know, that's something we can certainly overcome by making sure we're developing really good training for people to work in that field.
Can we just get a clarification? Someone's asking on the chat. Was the language that you mentioned that is broader, is that being implemented only at the state level or the city level, and how are those related? So
these are changes to state law that we are going to implement on a local level, right? So as a city, we have the authority and the responsibility to make use of these state laws. So it's really an area where state law is kind of authorizing local policy. So to be real clear, we've kind of already started interpreting the law more broadly in terms of how we direct city personnel. So the outreach teams that we have under city contract to engage with people, the actual teams we've created where we have nurses paired with police officers that are now canvassing the subway system. We've been doing this a couple of years now where we have given people the direction that they should think about danger to self more broadly than they perhaps have in the past. We've also given that same direction and really very specific training to the doctors who operate in our city-operated hospitals. We don't really have the authority to do that for the folks who work in the private hospitals, but to the extent we can kind of get information to doctors, we've already, I think, gotten that word out and have really seen some real differences already. The state law, I think, will probably go into effect to actually make it explicit that this is the right path, I think in a few months. But again, this is really codifying what is already the law. I think it's important to understand this is not an expansion in the sense that we can't do it now, but suddenly we'll be able to. This is about making clear what a currently vague law actually means, and we haven't waited for that law to be changed to go out and start doing that.
Yes, I want to thank the panelists for the discussion. My question is, our life on the screen, the age of artificial intelligence, who create more virtual perception of the reality of our society, can increase the mental illness from harassment online, addictions, from the life on the screen. Our new age of the technology on the phone can be a cause of mental illness issue.
I'm sorry, I'm not sure I entirely understood
Is the question about the youth in particular and overuse of digital technology and that leading to, is that?
Yes.
Yeah. Okay, so I don't think there's any evidence that the types of mental illness that we are talking about here tonight, right, the illnesses that cause psychosis and mania, mostly schizophrenia and severe bipolar disorder, those are biologically based illnesses, and I don't think there's any evidence that experiences such as you're describing, although I do think they can cause mental health challenges for people. I don't think they cause the kinds of illnesses that lead people to need care in psychiatric hospitals unless they're making them suicidal.
But I would also say that here is also a place where I'm seeing a little bit of optimism in society, where we're seeing that it can create problems, even if it's not schizophrenia among the youth, and we're moving back. We're having serious conversations about school bans, and maybe we'll have at some point more conversations about use of more physical books again, and less digital media. So I think we're actually a little bit more sane about those questions now than we were, say, 5 years ago, where especially in the schools, it was just like we can't, do too much of it. Yeah.
Hi, I want to commend you on the work you're doing in this area. I have firsthand experience. I live in a MICA shelter in Hell's Kitchen. It's kind of a long story how I ended up there. I'm working on a book right now about the situation, but I'm curious in your work on this and looking at other countries like Norway, and I don't know if you've gone globally. My great uncle was a psychiatrist and a chancellor of a medical school, and he was involved in Central Islip. There was a mental, there were feelers being put out for him to come and shut it down, and he didn't think it was the right decision, and he ended up in Omaha, Nebraska, running a medical school. But I'm curious if, looking across the globe, if you know the statistics, on a per capita basis, does the United States have one of the higher levels of mental health problems?
I mean, I just find people make estimates, but I just don't know how much stock I can put in those estimates. I mean, diagnoses, even within our own country, have changed over time. Even when you have somebody doing a really deep, intensive clinical evaluation of somebody, they can come up with a slightly different answer specifically of what the diagnosis is. And so, social conditions, high poverty countries in the middle of a civil war, I mean, it's just so hard to know how much credence you can give any of those estimates. So, yeah, I don't.
It's difficult. I'm wondering if the countries that have more of a socialist type of economic system, I'm also a former Wall Street analyst. I was an equity research analyst. I keep saying we live in a, pressure cooker society. They want us to grow to infinity on a finite planet, and it's just not, that's not possible. It's not sustainable. And there's constant pressure, especially if you work in corporate America for a publicly traded company. There's all kinds of pressures. The social media was brought up that's affecting so much of the youth. So I was just curious, looking, across the globe, if you had seen any differences with respect to like an economic system, but you brought up places where there's war and extreme poverty, and I know it is difficult. One other thing I wanted to ask you, the program that you're talking about, the involuntary, would that, looking at it at a more granular level, would people be treated with both looking at cognitive therapy as opposed to just medication? The reason I'm concerned about this, I was treated with medication for anxiety and depression when I was a Wall Street analyst for stuff that was going on in the environment, and it caused very dangerous effect. I tried to commit suicide twice. I am not the kind of person that would ever try to commit suicide.
Yep.
And they discovered it was the medications that were doing it. So that's a real concern. Are people potentially being put in more danger because we're constantly having this, pipeline of new medications coming out, and they can be very dangerous. So that's something that I kind of wanted to put out there and to see if that would be something that would be considered in the treatment program.
Yeah, so, right, so, as I said at the outset, I'm not a clinical person. I'm not a person who can really speak with authority about mental health treatments. I kind of leave that to others with more expertise. My focus is on getting people into the treatment system and then letting treatment professionals make decisions about what kind of treatment is appropriate. My understanding of what happens in our psychiatric hospitals is that it's absolutely about much more than medication. Cognitive behavioral therapy is certainly something that's integrated into the treatment we provided, and talk therapy and all kinds of other important supports and things are provided. My sense is that for people who have the most severe forms of mental illness, that it is a rare case where medication isn't part of the equation. And I've seen, look, medications I think have come a long way, getting better all the time, and we're all kind of hopeful if, the Trump administration hasn't completely shut down the important research that's happening, and that there might be breakthroughs around the corner. It's hard for me to embrace an idea that we should need to move away from medication as an essential component of treatment for people with the most severe mental illnesses, because I don't believe that for very many people recovery is possible without it.
Thank you so much. Thank you to the presenters and everybody who attended today. Yeah.
Oh, thank you. Thank you. Thank you all so much. This is really enjoyable.
Thanks again to the library. Yeah.
Yeah.